Okay, thank you very much. Special salute to domain number 6, in which the entire template became unmoored from its foundation and started to float around. So thank you for working under those conditions, but you all did great. Our next challenge is we have 19 groups to share your top line items in 1 minute each, okay? So let me demonstrate how we'd like you to do that, and you only get a minute. So I'm going to go first with my made up subdomain here. Okay, there's a timer up at the top. I'm starting it. I got 1 minute. Hi, everybody. I was in the early childhood obesity domain. Our group was working on access to resources, and we thought the low-hanging fruit was to go ahead and publish this framework that we've already put together for obesity prevention. We have the science, we have the data, we've already have the framework, so we're going to publish that. Over to the far left, we felt that the Department of Education at the federal level, implementing the policy would take more time and energy, but is very important. So that's in the upper left quadrant. And then the school health guidelines, we feel that those are distributed out amongst the states, but it might take some time to really get down to the ground level and to see some results from that. Let's move into our timeline. But before we do, our motto was, once again, a healthy child requires health information, and that will continue to be our guiding principle. So for our timeline, oh, I'm out. I only have 4 seconds left. Time's up. Okay, it goes fast. And we're gonna start with domain 6, since they had the greatest challenge and the most handsome team members. Okay, so let's get down to domain 6. And we are gonna start with self-imposed organizational culture impatience. Go ahead and unmute yourself, the host, and you have 1 minute.
Okay, our motto was healthy culture enables oh wait, that's not me. I'm B, go ahead.
No problem. So our motto is healthy culture enables interprofessional trust and efficiency. And really, I think what I'll do is go kind of in that timeline. We have 3 different work streams that we highlighted in this. And the first one around creating a policy statement, really standards of documentation. The next work stream around some informatics competencies and around governance, clinical ladders there. And then the third one around really that culture change and elimination of duplication, but really leveraging our interprofessional teams and trust to be able to trust each other and also getting to measuring that change. I haven't had 6 seconds left.
Ooh, excellent. All right. Over to Team B.
All right, so this is Jeff Nielsen, and sorry for taking 2 of your seconds. So our motto is a healthy EHR prioritizes brevity and relevance. And ours was self-imposed things that people put on themselves in the outpatient setting. We think that, first of all, we're going to require medical executive leadership that promotes healthy documentation practices, and that has to come from the highest levels to push back against some of the things that will always come externally to convince us that we need to be documenting more and more. And I think that goes along with the presentation that was said earlier today. If you look at our work streams, what we talked about is the MedExec was first. And then we think that there's significant tech innovation that will help us to streamline some of those items, and we know that that was a separate section. But I think that we have to make decisions on it, like on an individual basis, on a hospital level, and submit those to the vendors so that based on our own cultural changes, so the vendors understand what those changes need to be. So,
all right, we need to jump to Team C.
Okay, I think that's me. Yes, so we were self-imposed for the clinical, for compliance, risk, and legal. And our motto is the EHR will not stop a lawsuit. So I want to, can you make it a little bigger, or else I need to get my glasses on? Can I focus? I'd like to focus on the timeline, because if we look at the short term for each of the 3 work streams, we thought those were important and had pretty high feasibility. So work stream 1 was to establish guiding principles for when we would add things to the chart and when we wouldn't, and then use those guidelines with some established governance. And so developing that established governance would be long-term. Workstream B would be define our standards of care. And so putting things together and saying, these are our standards, this is what we're documenting, and that's it. And get people to agree collaboratively. And then data-driven is the last one. And I know I'm out of time.
Thank you very much. Okay, group D.
Okay, that's me. Bad documentation is worse than no documentation. We only had 2 work streams. One was in professionalism and education, and these are things that will take a very long time. And that includes focusing on the quality of care versus the quantity or even quality of documentation, and the idea of team-based charting, that if one person documents something, it shouldn't need to be repeated. That's going to take education going back to medical school and nursing school, but we thought it was very important. The other stream was organizational and culture change, and the biggie we wanted to do was restructure billing practices so providers are not picking billing codes. That's not our job.
Perfect timing. Speaking of billing codes, let's wrap around here to reimbursement.
Okay, well, good afternoon, everyone. In the reimbursement group, we didn't have time to get into a lot of detail, but we did complete a broad overview of opportunity. Our principle, I don't know if you want to make that bigger, is reduce clinician burden by eliminating billing documentation. And our top 3 ideas were eliminating the current system of billing, standardize among all health plans how billing is done, and automate the billing documentation process. We defined the general steps to take in our timeline and agreed that priority number 1, eliminating the system, is the most effective and most durable, but will take the longest and has the most hurdles to success. Automation and standardization can be faster and can be mutually beneficial to each other. Those steps can happen in a much shorter period of time where we can see some of the benefits of their mitigation, but elimination is the ultimate goal. That's it.
Wonderful. Thank you. Yes, the robots will figure out what we need to be paid for in advance, hopefully in the future.
Yep.
All right, over to regulatory. Group A.
Good afternoon, everybody. Jigar Patel. So the way we broke apart the problem was developed into the timeline, 3 basic areas to go address. What are the tenets for regulation, the stakeholders, and the regulations themselves, with the goal of having a patient-centered, non-disruptive, relational care enhancing regulation framework. So we broke it into a possible framework, put it back together to the motto statement. Obviously, lots of high effort things in here, as well as some things we can do in the immediate short term. That's what we have.
Wonderful. All right, over to Group B.
Great.
Accreditation organizations and patients.
Great. So our motto was congruence, contextual, clear, concise, and clinically relevant. And that refers to both regulations as well as documentation. And so looking at our timeline, we thought that starting with care plans and behavioral health treatment review, looking at their use, purpose, and value would make sense in the short term. Long term in that work stream is pushing accreditors to look at quality rather than quantity. So ways to measure quality of notes rather than just quantity of items that are ticked off. Our work stream B is having a more focused approach to adverse events, better than a litany of corrective actions, and having outcomes that need to be evaluated and reassessed in that regard. We then see, and that's in the short term, we then see important things in the medium term, which we really did focus on, is thinning out regulations and specifying that they should be based on evidence or patient safety issues, so specifying criteria for the regulations.
Thank you, Sarah. And over to the last group in regulatory, Group C.
That's me. So our overall statement was use evidence to reduce documentation. And this really is evidence about regulatory and accreditation policies. There are three main areas that we were targeting. One is evidence-based regulation and deregulation. One is a single source of truth. And three is to begin to set up a process for de-implementation of regulation and accreditation. The overarching concept behind all this is that there is no single source of truth, and that regulation, no matter where it comes from at the institution level all the way up to these national organization level, and even often the federal level, is that there's not clear evidence behind it. And so we really want to establish a method to get that in place and use it to drive these processes done.
Thank you, Trent. All right, on to the quality domain, beginning with Group A.
So that was our group. Can you zoom in? So our motto was quality is in the eye of the beholder, necessary, basically necessary and sufficient. And so if you go down to, so we basically thought that most of our items were of high importance. So we talked about having the state and regulatory, the federal government have a minimum data set for quality reporting, and in the short term, doing the work to communicate that to the federal government and state governments, and having convincing regulatory bodies to communicate to organizations that it's not necessary to document quality items that are no longer relevant, that it's okay to get to reduce that fear. And then in the long term, working with professional organizations to help define what those minimum data set of quality indicators would be. And then another work stream was actually work.
Time is up. We need to move on, but thank you very much.
Okay, thank you.
All right, on to Group B.
Okay, if you're gonna zoom in a little bit, please. All right, so our overarching goal is to have measures that matter to a person's health. So that's the driving force. So it's just like revising the E&M coding rules, we really need to redesign the quality measures as measures that matter. So then it would be up to the EHRs to make the information upon which these quality measures are derived to be in your face during the encounter. So rather than screen 36. And so when that QM information becomes useful for care, that would make any entry that you make, any effort you make, more worthwhile. And that gets the clinicians to engage. Timeline wise, short term, organize what's already there and make it more findable. Medium term, bring forward the key useful data at the point of care, sort of in your face, and that increases the value, that increases the maintenance, and that increases the use. So longer term, really, we need to change the measures to measures that matter.
Thank you, Paul. And the third group for quality, healthcare organization itself, inpatient.
Terrific, thanks. So our motto was documentation adds value to communication and decision making. We really wanted to have a positively stated motto, but if it had been the negative side, it would have been quality auditors, it's not all about you, right? So the idea prioritization piece, that purple sticky note, is sort of the ultimate goal of, we'd like to see the creation of national, even international, we had a Canadian in our group, standard answering the question, when is it documenting against a checklist adding value? And we think that's not actually known. We know that checklists have been shown to add value, but we don't know if documenting against them is the difference that makes the difference. We think that quality assurance or quality management activities should be done via real-time observation as much as possible, and that checklists can and should exist as guides and reminders, but they're not our primary education. They're not for orienting new staff, and that maybe they shouldn't be documentation at all. So I'm using the word checklist here in a generalized way around standard of care, that the standard of care probably doesn't need to be documented into the EHR. And we made this all one work stream. Thanks.
Thanks, Bonnie. All right, now to the monster usability group. We'll start with human factors design inpatient.
Yeah, I think that's so if you don't mind zooming in a little bit more, there we go. So our motto was new conceptually based documentation tailored for you and me. And you know, from an idea of prioritization, though it's not, you know, maybe not fully low-hanging fruit, we said novel modalities and role and context. So really that means, you know, what we're seeing with mobile devices for documentation and voice being incorporated to reduce that kind of burden. From the kind of middle tier as far as feasibility and priority, it was really creating like a tailored conceptual based EMR. So really changing the skin of the EMR together and integrating that into workflow. The thing that we saw as the most high importance but low feasibility was the regulatory piece, and that brings us to the timeline from the work streams, and we kind of go from high to low. So work stream A, each one feeds off of the other, and the first one being regulatory and policy. Okay.
Thank you, Karthik. It's fast, I know. All right, over to usability. Oh, B, human factors, ambulatory.
Okay, our motto, right clinical information, context, time, message, and effort. We spent a lot of time on idea prioritization, basically across what looks like 4 work streams that we're just now starting to paint for everyone. The key areas in yellow had to do with, shucks, I've lost my notes for this, but basically alternative formats to text as a way to making sure that we can document information that is usable by everybody. Language inclusivity, you'll see is on the sort of upper right. Then we had equitably sharing the documentation responsibility, which essentially was code for basically spreading out the roles as much as possible. In the green, which had primarily to do with foraging, we wanted to make sure that we had optimized sharing of information, lifelong EHR learning, which is one we think is extremely important, and workflow-centric assistance, the ability to ask for help or getting more information in the workflow and receiving it. We wanted to make a point that said all of these were both patient and provider centric and assumed equity. In the pink, AI-enabled EHRs was one of the ways we thought about improving visualization, as well as making information available and that is context aware. Thank you.
Thanks, Kevin. Right. On to usability, a lack of thorough training. Inpatient.
All right. Our motto was best practices, ongoing training, evaluation promotes optimal usability. And if you'll scroll down to our timeline, We had three equally related work streams here. The first was to identify best practices and to ultimately develop and disseminate a toolkit of those best practices. Coupled with that, we want to give an award to those organizations who are identified as having best practices and willing to share and disseminate. So there would be an award mechanism. And then our third work stream was all around simulation best practices in both the academic and the practice setting to also identify those best practices. But we also recognize that often funding is an issue with getting simulation centers where they need to be for adequate training, and particularly within the clinical workflow. So we think there needs to be a federal funding stream, but we also recognize that it could be a test environment for evaluating documentation, minimizing documentation as well.
Thank you, Susan. All right, the lack of thorough training. Ambulatory.
All right. Well, we really just had sort of one big idea that was captured in our motto. So we didn't prioritize because it was pretty clear what the priority was. Our big idea is that essentially the training paradigm today is broken. And so we need to shift the way that training is thought of so that it shifts to one that is about sort of ongoing, where there's perceived a need for sort of investment because there is a high return on investment to investing in training. And one that is integrated, both in terms of integrated into daily work, as well as clinicians and frontline users who are integrated into the training process. And then, wait, you've lost my motto. I need the last word. Can you scroll up? Sorry. Personalized, the idea that training is not one size fits all and that it needs to be personalized. And we talked a lot about the need to personalize it to the career stage with a particular need to set good habits when people are in their training phase, as well as thinking about the specific needs of the individual. Overall, to achieve this paradigm shift, I think it's hard because—
Sorry, Julia, out of time.
Oh, okay.
All right, and on to workflow, inpatient.
Judy, you're on mute.
Sorry. Workflow and workflow and EHR tools must complement each other. We came up with 6 priorities. They're listed there. If you could zoom in a little bit so I can read them. Basically, it has to do with the idea that the devices and what you're doing, the function you're doing, whether it's information retrieval or whether it's documentation or whether it's putting together the patient's story, we need that to be real time, and you need to be able to do it in various ways depending on your role and your task. And I'll leave it at that because I know we're running tight on time.
Thank you, Judy. All right, workflow ambulatory.
I guess that's us. No, it's not us. We're 4F. Okay, that's us. Making the system support us, not vice versa. Can we go down to the list, or, well, I'll just do it from memory. There we go. So on technology, we want better voice recognition, which is now possible, to be integrated into the workflow and to make it affordable. We want vendors to be transparent, to be forced to be transparent about what clinicians request in terms of improvements, so that we can all see what others are asking for better. We want standards to be enforced to remove, yet once again, the hold harmless and learned intermediary clause that prevents us from seeing. We think we should revision workflow in such a way that we can make it work for the patient and for the clinician. And we want audit of regulations to make sure they are correctly interpreted and not overburdensome.
Thank you, Ross. All right, stick with us. We only got 2 more groups. We're moving into interoperability. Insufficient standards internally within an organization.
So that's me. Our theme is don't redocument, share and retrieve. And the object was to bring information together in a useful way. And we talked about working with vendors to identify standards for practical interoperability. We recognize that there's oftentimes granularity associated with this. We looked at labs as an example and talked about how we could identify the appropriate, bring together the important people and identify those appropriate areas that we would be able to apply it to other areas such as medications and problem lists in the future. So we improved the usefulness of that information.
Thank you so much, Lorraine. And our final but most important group, interoperability and sufficient standards internally between organizations.
So our motto was clear and consistent standards, easy to access and use. We had 4 ideas. If you work down to the timeline: demographic purity, short-term evaluate the impact of US CDI. I don't think that was for me, unless that's the fastest minute ever. And engaging consumers and other stakeholders in terms of what is of value there. And then, of course, improving potentially with a longer term path to a unique patient safety identifier, harkening back to HIPAA. And then the 2 workstream B and C are synchronized in that they are C follows B, and it looks like I'm either out of time or not. It's a little unclear, but let me go real quickly that
Andy, we're going to have to call it. So thank you so much.
All righty.
Thank you, everybody. 140 something talented people, 19 subdomains, 5,000 ideas, all of them doable. Appreciate you. Over to Sarah Trent to close us out.
Great, thank you so much. And I know we are just a couple minutes. I know we're a couple minutes over time, so I appreciate your patience and hanging on for a few minutes as we conclude. So that this conclusion will only be a minute. So that everybody is aware, you will have access to the AMIA Connect community for 25x5 to stay in touch with everybody. So where are we? So we have all recordings and chats from the Symposium series available online. As I said, you'll have access coming soon, if you haven't seen it already, to AMIA Connect, even for those that are not AMIA members. Breakout, our outputs, we're going to draft an action plan from them, and we will be making that information available, again, pointing to our website for that. So what is next? So we're going to be developing reports focused on future needs in the action plan. Our goal is having an executive summary by April 1st. That's, intending for a one-pager, and then to follow that, a full report, which will really be a cohesive overall action plan to fine-tune the work. Additionally, we're looking towards peer-reviewed and white papers for dissemination. As a second major step, we want to create a network of allies. So this would be a series of dissemination activities and conversations about what we learned and the actions that we have for moving forward. This is starting just next week, where we will be presenting and sharing these ideas and refining them with ACME, the American College of Medical Informatics, which is part of AMIA. We also have some submissions and planned presentations at some of the upcoming AMIA symposiums. So AMIA Clinical Informatics Conference in the spring, and then we plan for something at the AMIA Fall Symposium as well. We also, at least so far, have a plan for presenting to the AMIA implementation work group. So this is just what's been planned so far, but we want more. Those are just our examples. And our third major action stream, work stream, if you will, is convening key stakeholders from the community to mobilize strategies nationally. So this would include, for example, the National Academy of Medicine, CMS, ONC, AMA, ANA. And we see these as convening sessions for strategic planning, bringing forward the content that you all generated, and then the formation of working groups from there and future activities and reports that we would hope could come forth from those organizations. So I don't want to keep you all too late. You have all been so wonderful. participating in this series. It's been a fabulous 6 weeks. Thank you to all of our speakers, our session leaders, our facilitators, our scribes, and our participants who were so active on the chat. And again, those are all going to be made available. So we're thrilled with the content that we have and where we can go from here. And I want to emphasize, we will be going from here. This is a movement that we want to continue because we really want this to have an impact for our clinicians and our patients. So thank you all. And with that, we will formally close the symposium, but continue the work. So thank you.
Thanks all.